Sure.
Okay, thank you.
Okay. Yeah, so we shall start these sessions on cybersecurity and telemedicine. Welcome everyone to this webinar. All right. So we have two speakers for these sessions. We have Miss Nicole Walz and Eric Wu, right, both of them. And without further ado, I think we will just invite Nicole to come in. Nicole actually is the Senior Global Business Development Manager for Patients Monitoring and Analytics in Phlips in Germany, right, with special focus system on networking products. So that put her in good positions for her to share with us some challenges, especially in telemedicine, where we will need to have some security in place for data to be transmitted. Okay, Nicole, please.
Thank you, John. Good afternoon, everyone. I have to be careful because it's 8:20 over here in Germany in the morning. So a very welcome from a very cold Germany to all of you. I'm very honored to be able to speak at this conference, and I've been listening into some of the previous sessions. Very interesting, so thanks a lot for the opportunity. Before I start talking about security, I would like to start with a very small anecdote. About 1.5 years ago, I managed to find a colleague in R&D in Phlips. And I walked into a space where I had never been before because I'm in marketing and sales development. So I walked into the R&D space and I started talking to my colleague who's responsible for cybersecurity on patient monitoring. And before we started talking, he said, you know, I've been doing this job for 8 years. No one from marketing has ever come to me to speak to me. I've been doing cybersecurity for so long, but you guys never cared. But now all of a sudden, you guys are coming to me asking, what is cybersecurity? What do we do? And he started laughing because it's been a space that's not really been interesting to us in previous years. It's been all about clinical, what can we do with our products? But all of a sudden we turn to those guys who've been doing their job, and we ask them, so what is this all about? Why is it important? And what is it that we actually do to protect our customers? So I'm just telling you this anecdote because I want to show you how this is a challenge for us in the industry as well, because we've been focusing on the clinical aspect, clinical side of things. But these days, it's about other challenges as well. It's about the danger and the threat coming from the cyberspace. So digitization in healthcare, is it a blessing or is it a curse? Of course, digitization is everywhere and digitization comes with a lot of good things. In healthcare, digitization has given us the power to access, analyze, manage and share data, no matter where they are. And that has been helping us to transform care to be at lower cost. That's the good side. But on the other side, because we have so many medical devices connected, systems and networks, our hospitals, our customers have become a lot more vulnerable because it makes a digital system is vulnerable to cybercrime. So looking at digitization in general, not healthcare specific, but in general, what makes the technologies special? There's 3 different areas. The first one is it's digitization, and these technologies come with increased complexity, greater ecosystems and supply chains. We have so many different products and they come from different vendors, different organizations, they come with services. Systems become a lot more complex. They're cyber physical in nature. It's a piece of hardware and it's a piece of software. Maybe there's a piece of service also connected to it. So you've got very quickly, you've got a lot of different parties involved in one solution, in one product, in one thing that you do. Everyone in the hospital wants interconnectivity. Hospitals want to connect everything. Interconnectivity is a good thing, but once you enter somewhere, you can connect easily into other parts of the system. And these products come with interconnected services. As Phlips, we often say to our customers, well, let us into your facility digitally, remotely, and we can help you without even having to send someone in. So we do have services that we offer to make hospitals' lives easier. but that comes with the fact that people can get into the system. Talking about intelligence, artificial intelligence, we can use predictive analytics these days. As Phlips, we also say to people, we have lots of data, we have lots of experience. We use that data and experience to do predictive analytics for you in order to make your life easier. And we have technologies that are learning, they're adapting, and they're evolving their capabilities, which is a good thing, but can sometimes also go into the wrong direction if you don't take the precautions that are necessary. And last but not least, don't forget about the human factor, the third pillar. We are processing personal and non-personal metadata without us even noticing as consumers, as customers, as patients. And there's human product interaction. We have humans dealing with these technologies, and these technologies often use our emotions, our reactions. Think about face recognition and technologies that can derive your mood or your attitude from the face that they're seeing through the camera on your mobile phone. So these are all things that haven't been there many years before. You know this, but we just need to keep that in mind when we think about what that means for healthcare. So why do we need to care about cybersecurity? All these great things about digitization, the fact that my car knows where I want to go and how long it will take me to go there. The fact that my mobile phone will take my migraine calendar and predict my next migraine coming or whatever, these are great things. But why do we need to care about cybersecurity? First of all, because if dealt in the wrong way, it can cause physical injury or psychological harm. Also, when dealing with private data, privacy can be violated if in the wrong hands, and people could be looking at you. Undesired surveillance could be happening, or identity theft is one of the worst things that can happen to people. That's another threat. The fourth one is about fraud, financial loss, and loss of intellectual property. If someone gets into your system and steals something from you personally, or in the office, or in a professional environment, that is a big damage. Number 5 is the impact that cybersecurity can have on society. For example, if someone hacks into a telecom system, which happened in Germany a few times, the internet of many people is down, and the passwords are stolen of thousands, millions of people. That can happen very easily, and that has an impact on many people at the same time. So it's almost on a big part of society. And last but not least, the last point, if you abuse the data and the technology that is at hand, you can manipulate people. You can be leading people into the wrong direction, and you can make big damage to people. So how to go about cybersecurity? When my colleagues ask me, and I can tell you that happens a lot these days, they say, so what is this about security? How do I deal with it? And normally I start with the CIA triad. I always say it's pretty easy. What you need to do in order to have a safe system or a safe enterprise, you need to make sure that the data at hand is kept confidential, integer, and available. Confidentiality means that not everyone has access to the data. You need to keep data confidential. Integrity, the data that you have shouldn't be changed. No change should happen without a trace. That's basically about integrity. And then last but not least, availability. If you have data and you need the data in our space to treat patients, it needs to be available at any point, at any time, and it shouldn't be lost. So these are the 3 pillars. They're easily spoken out, but there's a lot behind it. But basically, it's all about these 3 areas, this triad. Now it's all about data. We said that. I'm gonna give you a few pictures. Why is it important? Why is it all about data? If you think about in our space, if something happens to a person, a patient is injured on the street, it starts with data. This guy is coming out with a machine ready to take data from the patient to see what's happening with the patient. So the systems and data are everywhere, even on the streets. And then, of course, in the area where the patient is admitted in the emergency department and later on in the operating room, our systems are connected because the people in the hospital want to know what happened to the patient before the patient even arrived in hospital. So systems are connecting. The emergency room is connected to the OR. The data from the whole journey can be available in the ICU later on the general care. So systems are increasingly connected. And then if you look at the moment when patients are getting better, if patients are getting better, we want to mobilize patients. We want them to walk around. And because we still want to know what's going on with the patients, we still want to take their vital signs, we equip them with devices that are wireless. So systems are also increasingly wireless. And of course, a very good thing is that our systems become a lot more intelligent. In our area in patient monitoring, what is very important is to make sure that caretakers don't suffer from too many alarms. We know today that sometimes a single patient, a single bed can issue up to 5,000 alarms per day. Think about the poor caretakers who need to manage all these alarms, and many of them are false alarms. So we have intelligent systems and methods in place today that help systems to distinguish already between false alarms, nuisance alarms, and real alarms in order to take the number of alarms down. So we can benefit from systems getting a lot more intelligent, and they can get intelligent because they're making use of data and experience and analytics. What's also happening, it's a big shift actually, that customers, hospitals are not only asking for products, but they're asking for services. Especially also in small hospitals, customers are asking, I don't have all the knowledge and all the people who can deal with all of this. Can you provide me with that service? Or can you provide me with a service that is remote, because I don't want to wait for 2 days until your service technician comes around. These are examples from the service space, but there's also areas where customers are trying to buy other services from us. For example, how do we reduce the number of alarms? How can we make our workflow more efficient? So we're shifting a lot more towards services because our customers are asking more and more of us as the manufacturer beyond the actual product. Now, integration of networks and responsibilities. If you look in the patient monitoring space, many years ago, you had a few patient monitors connected to a box, which we call a central station. And that was a network in itself. A medical network, it was completely isolated from everything else. So where's the problem? Where's the danger? These systems are actually pretty secure because no one can get to it other than physically accessing these systems. But these days, customers are asking to connect to other parts of the hospital, which results in the fact that all of a sudden you take a medical network and you connect it to a normal IT network. So you're opening it up to a much bigger space, and with that to much higher threat. And this is where the change is also happening in our industry, that the biomeds who used to be responsible for the medical network now need to talk to the IT guys because they depend on each other. It's not always an easy conversation. We know this from experience, but this is the shift and the change that is happening. Because at the end of it, it's about shared responsibility. It's about the responsibility of the caretakers having to take care of their patients. It's about the biomedical departments being responsible for making sure that everything is working. And of course, it's about manufacturers like us who need to enable the customer to do their job. Very often customers ask us, are you compliant with this standard? Are you compliant with GDPR, which is the data privacy regulation in Europe? And we're like, the only thing we can say is, we can offer you the tools to be compliant yourself in the hospital, but it's about a shared responsibility. We can give you the features and the possibilities to do something in the system, but it's about the hospital, and that's the clinical people, the biomed department and the IT department to work together to make a system secure and to make sure, coming back to the triad, that confidentiality, integrity, and availability of the data is secure. So it's not the job of a single department in the hospital. It's not only the job of the manufacturer, but it's a shared responsibility between the different parties that are acting in that space. Now, let's look at what security challenges mean for healthcare. First of all, they're not any different than for any other enterprise or any private person. On the left-hand side, you can see the typical things that can happen to a private person and to an enterprise. It's CEO fraud, emails getting to you that look like they're coming from your boss or your HR department. It's about phishing and spam emails. It's about malware. Same thing happens in hospitals as it would happen to people in an enterprise or at home. On the right-hand side, you can see unauthorized access to theft of systems, unauthorized access or theft of sensitive information, and then last but not least, the worst thing that can happen to you in a hospital, the unavailability of systems and data. That's the damage that a hacker can do to your organization, but that's no different than you would experience at home or in any other enterprise. So the security challenges are the same, obviously, but yet the impact is slightly different or slightly more critical, because if you look at the healthcare landscape on the left-hand side, in healthcare, we're rapidly moving towards digitization because we want to enable more affordable, more efficient, less intuitive, and more personalized care. We want to do everything to make hospitals more efficient, make their lives easier, etc. So we're making use of that because there's a clear goal. It's not just about convenient and consumer space, but it's about the work that is delivered in hospitals. And often these spaces or the hospitals are 24/7, and these businesses, the hospitals, include large staff, and that's not only their own staff, but contractors. So many people are actually acting in the landscape of a hospital. And if you look to the middle, from the technical side of things, there's so many different systems in a hospital these days, medical and non-medical, and third-party maintained systems. They're not only under the control of the hospital. And unfortunately, many hospitals still have a lot of legacy systems, a lot of old stuff in hospitals, medical and non-medical. Unfortunately, the old stuff often doesn't really break. So in many cases, you still see very, very old equipment. I can speak for patient monitors. We have some very good, reliable old technology in hospitals, and people don't want to get rid of it because it still works, which speaks for quality. But on the other hand, if some of these devices run on outdated operating systems, like for example, Windows 7, it's fine that they still work, but they're vulnerable because there's no more security patches. It's easy for hackers to get in and do damage. So legacy products are a big problem, especially in hospitals. And last but not least, the human factor. The impact of the ability to provide care is huge. If anyone does damage to a hospital, the impact is huge. It's not only about not being able to work, it's about patients' lives in the end. And then last but not least, the data in hospitals is very sensitive and should be subject to very strict confidentiality requirements. So that's what's special. So do we manage on risk or compliance? That is another dimension that I would like to end of this presentation. We manage risk and compliance. Compliance, IT people say, do you comply with this? Can we comply with that? We've got security regulations in place. Healthcare providers also have to manage the risk of losing a patient because of care that cannot be delivered to the patient. So often the question is, do we put security measures in place to protect the system, but what about the safety of the patient? And that's where it becomes a very tricky discussion, especially if you have biomeds involved in the discussion, clinical people and IT people, because information needs to be at the fingertips of clinicians, and IT would like to put a lock, a password on everything to protect the data, which is their job. So often you do have a conflict there. And that basically, that's this bubble here. you have the security-related risk, which is about systems, making sure that your systems are up and running, their data is kept confidential and integral. That's all very important. On the right-hand side, the right bubble is safety-related risk. The safety-related risk is about the human being, the patient needing care. And those two come together, and of course, they are both very important in hospitals. But we need to look at every single situation and what kind of measures we take in order to protect the security of the system and the safety of the actual patient. If you talk to IT, looking again at the confidentiality, integrity, and availability, IT says, you know what? My job is to protect the confidentiality and the integrity of the data. Availability for me is, okay, if the system breaks down, I'm going to go fix it. So for the IT people, integrity and confidentiality and protecting that is the two main things. If you talk to operations, if you talk to the clinical people, to biomeds, they say, you know what, I don't mind, well, I need to protect the health of my patient. I need to have the data at any point in time, anywhere, and it needs to be the correct data. Otherwise, I may be doing huge damage to my patient. So if I lose a patient record, if someone gets into my system, or it's not protected to 100%, I can live with it because I just need the data and the integrity of the data. So you can see the three different areas are important to both, but there is a different emphasis depending on who you talk to. So what is the key? The key is really to talk about the right balance, to have the right balance, to talk about safety and performance and have that balance. You need to have the performance of the system. IT, yes, we do that, we understand that, but we also need to make sure that the safety of the patient isn't at stake. And the solution that we're operating needs to fit the intended use, the second bubble from the left, and the intended operating environment. I often say that if you are about to resuscitate a patient, you don't want to mess with passwords. If IT says they need passwords, but you need to save a life and you need immediate access to data and systems, you don't want a password. So that's just one of the examples where there can be a conflict. So the security measures need to fit the environment that the devices and the solutions are in. And in the third bubble, something that we like to address very often is the entire life cycle. Just buying a product doesn't mean anymore that it will last for the next 10 years, it will be secure. It needs to be maintained over the entire life cycle with updates, with patches, with everything. And then we need to recognize the differences, last bubble, for products, services, and organizations, because depending on what you're dealing with, you need to apply a different standard, different security standard, different security measures. And that's basically the end of my speech. There are some viruses that doctors can't treat. That's the closing statement before I'm looking forward to any discussion in the next presentation.
We do have 5 minutes. Probably just one question that was posted in the Q&A, saying that actually blockchain technology, will the blockchain technology improve cybersecurity? I think in the first place, what we should look at is blockchain technology is actually in place in some of these medical devices and the system, Nicole?
You know, there's many things that are inside the systems. When I talk to my IT guys, the security guys, there's a multitude of things that are in the systems, whether it's encryption or node authentication, if it's blockchains, if it's whitelisting. There's many things. I think it's the combination of different things. But the other thing that a security guy will always tell you is that there is no such thing as a 100% secure system. That's the other thing. We can put many things and new things in place. We have to just monitor our systems on a regular basis. And if there's a vulnerability that comes up, any open hole, then we need to fix it. And as a medical manufacturer, it's crucial that we fix that the moment, or start fixing it the moment we find out about it. So I would say, yes, of course, everything will improve, but it's a combination of many things.
Okay, yeah. So given the gap in recommended practices, mitigations measures, and what can be realistically implemented in hospital, is it a best effort approach good enough?
Yeah, it depends. You know, if you look at a system, I have to refer to it because that's where I come from. Patient monitoring, you know, I said to my colleague, well, you know, what is my heart rate worth or my respiration rate? Is it really worth stealing that data? Isn't it more important to steal my health record, which has my medication and my birth date and my illnesses? And it's, yes, of course, it's more vulnerable to steal my patient records. So hospitals also need to look at the kind of data that they're protecting. I would put the biggest lock on the electronic medical record. It's up to the risk management system in the hospital to figure out, is the best effort approach enough for a specific system or not? It's a difficult question.
I'm
Hi,
sure.
sorry to interrupt. Can we go on to Eric's talk first, and then we have the remaining questions for Nicole answered after that.
Sure. Yeah, because it's not the 3:50. Nicole says the time till 3:50. It's okay. Yeah.
Yep.
So I think thank you, Nicole. I think we'll come back later on for the Q&A sessions again. Yeah.
Looking forward to
So
it. Thank you.
yeah. Okay, so we will invite our next speaker, Eric Wu. Yeah, he's a regional director for ECRI Institute Asia Pacific. He has been doing training for quite a while in terms of the standards, standardizations, and delivery of the healthcare system standards. Yeah, Eric, please.
Thank you. Thank you so much. I'm just trying to get my screen shared. Okay.
Yep, you're on. Yep.
I'm on. Okay, good. Good afternoon, everyone. I am between you and going home, so I'm the last speaker. So I hope, please bear with me. I will run through this. Thank you, Nicole, for sharing, and thank you, BES Singapore, for inviting me for this wonderful forum and conference that we have. Miss coming back to Singapore, but now at least virtually I'm back in Singapore for a while. What I want to do is really to share not so much difference from what Nicole has been talking about, but diving it from a different perspective. So we're going to look at how challenges of design, interoperability, impacting telemedicine itself. So I'm not going to go into introductory of a lot of different things, but I just want to show you all some facts very quickly. This is a study report that I found from WHO. They actually been monitoring the uptake of HIT globally, and the record started year 2000. And what they found in the report that they published in 2016 was that between the year of 2010 to 2015, there's a huge spike of adoption. So almost 46% adoption during that 5-year period. And the country involved in this particular monitoring survey was actually 96 countries. And you can see that more than 50% of the uptake and adoption of health IT is from higher income nations, and more than 60% of them are from middle income nations as well. Well, like Nicole mentioned, the whole reason why people are jumping into this and trying to adopt health IT into their clinical work every day is because of the improved clinical operational efficiency and effectiveness. So everyone saw that benefit and that wonderful good thing that health IT can provide, and that is the reason why everyone is jumping into it. And of course, higher income nation, upper middle class income nation, they have fundings. Fundings are available both in the public and the private sectors of the health industry, and it is really trying to build that momentum using this funding in adopting health IT itself. And of course, being those nations that are a little bit more developed in the infrastructure, in the ecosystem as an overall, that has benefited the adoption as well in that sense. To a certain extent, some countries has very good legal framework, particularly like in the US, there's a good HIPAA and high-tech act that is governing the whole use of IT and in healthcare itself. More importantly, I think as well is people. We are seeing a lot more younger generations and people getting used to IT itself, and people are starting to feel that health IT is benefiting, and that is why people are learning about it. People are really getting into using it. So the availability of competency is actually getting higher. So these are all the good news about how health IT are being expanded and adopted throughout. I want to show you a little bit about telehealth, since that telemedicine is one of the topics I have to talk about. This is a blueprint from Malaysia. We're thinking to look at connecting health provider in all forms and sizes, particularly primarily in consultation and diagnostic, to utilizing the multimedia and to the public consumer or patients themselves, institutions, to health suppliers, financing, and even to researchers in universities in that context. So this is really where telehealth is moving and hoping to move forward. Just want to illustrate this because this is a blueprint that they have in Malaysia. But this is a very grand, big blueprint, easy to look at, very hard to achieve. And let's go into some of more details into the situation today. Interoperability in the hospital setting. We all know integration is happening, particularly in Singapore. A lot of your hospitals are integrated one way or another. All these components within our diagnostics, our caregiving processes are now integrated together to provide efficient, effective, accurate, minimize care delay time, improve in accuracy of information, blah, 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 and all that. So these are good things that are happening. Telemedicine is leveraging on the availability of such network that is in existence. Telemedicine will not be there if we do not have the foundation of the healthcare provider to support it. So very much telemedicine leverages also on the providers that is in place and the system that they have in order to provide some form of telecare to a patient itself, right? So this is just a diagram to illustrate that. You can see things like remote monitoring is possible, but you still need the foundation of a health facility to do it. To look at patient portals is possible. You still need to connect back to your healthcare provider's database so that the patient can access those information themselves and so forth and so on, right? So just a model to illustrate that telemedicine relies very heavily on the healthcare provider's backbone system or the data and the integration that is in existence when they adopt health IT before they move to telemedicine itself, right? So once we look at all these models and that we understand, excuse me, that telemedicine requires this sort of support, what are the challenges that we see? And what is this interoperability challenge that I'm highlighting? And I want to talk about more in details and how it impacts as well the telemedicine world that is coming to us, and if not already in existence to us in some countries as well. Some reports has actually been published a while ago. There was a report from 2007 to 2018 that this is just one of the reports that I found. 18,000 adverse events related to electronic health records. Integrating everything into the electronic health records, it has actually contributed 18,000 adverse events, although there's only 3% that is harm, that cause harm, and 7 deaths. But this is just one of the reports in the world that it is. But I want to use this just to illustrate an example or a point that electronic health records that are available to us today can cause harm. And every other day while we are doing our patient safety organization work, I'm reviewing some of the RCAs, and we still see that electronic health records are causing harm and problem to patients itself, let alone the entire integration that we talk about in the hospital itself. 2019, a survey actually found that 1 in 5 patients, they realized that their own medical record has error. 1 in 5. And of all those errors, incorrect medical history contribute to 9%, incorrect personal information 5%, incorrect medication information 3%, incorrect lab test information 3%. And in the US, they found that CPOE errors contributing to medication error is the it's actually the third leading contributor. CPOE is the third leading contributor to medication error in the USA today. So a system integrating with EHR, ordering medication from pharmacy, channeling the administration information to the ward and stuff like that, that has been causing medication errors. So not only that other medication error exercise is important, but CPOE has been really one of those issues that they've been looking at. And around medication error, for example, you looked at, this is a report as well that has been published. CPOE is highest, as I mentioned. Pharmacy systems itself, this is the integration problem. And this diagram and this particular slide, I'm using it to illustrate that there is an integration issue that is still happening. The interoperability between the system is still causing error itself. And one of those errors are medication error. And if you look at the various points of medication error, dose omission, extra dose, wrong dosage that's been offered, you can see that all these related systems that are integrated to offer care to a patient itself have and it will continue to produce adverse events. And so that we need to take note that this is still a problem within the interoperability of a system in the hospital, right? Just want to use a case to cite a real life example of really what's happening. Then order for a medication and the label and the particular prescription that came was not the same as what the order form looks like. So what happened was that the system itself has totaled up the amount of medication, and the people who's looking at that system saw a accumulated number of dose, or rather than the individual dose of the different medication that was provided, that was supposed to be ordered and provided for the patient itself. So that resulted in delay in care for the patient. This looks like there is truncation of information transfer. The interface and the dashboard, when we design the system itself for interoperability, did we actually think about what we need to see in the front line when the nursing staff or the personnel who's going to administer or dispense the medication to the patient? Do we think about what it's important for them to see and how it should be actually displayed in their interface itself? Does the design of the interoperability system lean towards billing or accounting or insurance requirement rather than the clinical requirement on that particular area of care? So is that one of those issues that we see? And I can tell you the answer is yes, but this is a case that I can share with you that because the display and the information was showing a total dose instead of an individual dose of medication, that resulted to discrepancy. It didn't harm the patient, but it still caused delay in care for the particular patient itself. And this is still happening today, right? I want to talk about health IT challenges and two considerations. So these challenges can be converted into considerations where we can improve, right? Key things to look at in the health IT perspective is actually in the interoperability. We see that when we interoperate and when we have system linking to system, things like missing data persist. We have seen reports on delay in data delivery. Not that it doesn't deliver, but there's a delay. Likelihood this is caused by legacy system or design of the system or hardware of the system itself. Basic data entry errors, we still see things like that, right? Patient data or patient associated errors, patient identification is the key thing that we looked at from here. And we see that using a system itself, we can actually identify wrong. Example, system in the ER and the system in the ward is different when they identify a patient. They use different kind of patient identification to identify their patient when they register the patient in the ER and when they actually have the patient in the ward. They found that there's two different data. And sometimes in certain reports that we found, the the two different numbers or the two different identification belong to two different kind of patients. And then wrong treatment has been provided to the patients as well. So these are kind of reports we see as well. Synchronization errors we see a lot as well. One of the key other things that we see as the biggest challenge for health IT or interoperability in the sense is human factor and usability. A lot of times when we design an IT system, we tend to design it the way we like to see it. But we say in the project when we built the HIT, I see many hospitals are telling me, oh, we have a very robust plan, you know, Eric. We actually sit all the user down. We have done a workshop understanding the workflow. We really thoroughly understand what the front line wants. We thoroughly understand what the management wants. And then thereafter, we design the platform and we design the integration or the system to intraoperate, right? But we still see reports. We understand that that job has been done, but we still see a lot of reports, like the screen has, the whole dashboard is very busy. There's just 1001 things in there. And then when they're looking for something, those are very difficult to see. Or I have to click 3 times to find one information that I want. Some informations are not displayed, such as notes, for example. Without those information, they don't have the note to understand what they need to do, particularly in drug administration perspective. So these are things that really needs to be further reviewed. I'm not saying that we're not doing today, but we need to really further review it because we're still receiving cases related specifically to that kind of problem itself. So we still need to really look at that challenges and consider what we really need to do about it. Workflow process design. A lot of times, the IT would have designed the system to work in a certain ways, integrated with certain medical device, and it works in certain ways. But do you not realize in reality, sometimes we have the front line not exactly following the workflow that is designed by the system. They work around the system and try and comprehend. That has been something that we noted, and that has been some reported case. And the root cause behind it was really because there's a mismatch between the actual work process and the system process that they have. And because of that mismatch, it opens up this very big gap of error platform. It allows and it is designed for people to make mistakes and for system to create mistakes. And we have seen reports over reports that tells us that that's the root cause that is happening as well. And as we design the system, and we can say we will have the best design of the system to integrate our hospital networks and equipments, and interoperability is fantastic. Did we test? How many times do we test? What is an adequate testing? Is there a follow-up test? How often should we really check on that? Do we only react when we receive a report on an adverse event, or do we only react when the system gets hanged and it doesn't move? What is the plan? Is there a comprehensive plan that includes, and quoting Nicole, for example, she was saying that it is now a world of IT, biomedical engineers, clinical people, and probably managers and risk managers as well involved in the whole, comprehensive approach to things. And when should we do what, and what is the protocol to deal with? What is the monitoring and program that has been designed? So adequate testing is very important. Should we retest? Should we have a periodical retest? What is it that we have to look at? So testing is very important to think about. And I see that it is always challenging to test because you have to test it live. And at the same time, we have to deal with the patient, and patients are still walking in. Clinicians are making a lot of noise because they need to use the system. They need to treat their patients. Operation needs to go on and stuff like that. And if you take time to do testing, things has to be stopped. I understand. But there's a balance that is required. So what needs to be done and what not to be done? Availability of system and information. In what position of the hospital should what system be available? Have they ever thought about the required system available to the right front line in the right area? That's also an important component of challenges that we have seen. Sometimes we hear that we don't have access to the system right now. We will not deal with it first, in certain area of care, which I don't think should be the right way of doing it. Comprehensive team member, adequate resources. When we decide to jump into this particular game or this program or this development or this innovation or innovative approach to things, We got to make sure that, we have right team members, the right competency, leadership support, adequate resources. Any of this missing, you're going to find problem trying to execute what you want to do, and very challenging to come up with the outcome that is desired from the original plan. So this has to be really thought through and have. Confidentiality and integrity is a key thing. I think most of the hospitals today, and some countries as well, who have the Personal Data Protection Act implemented, that will be part of something that we will do anyway, because there's an act that we have to follow. So that's important. Cybersecurity, I think Nicole has also mentioned a lot. I'll touch a bit about that as well. Should we lock everything or should we not lock everything? And if we lock everything, what's the point of integrating? If we lock everything so difficult, what is the point of having any interoperability anyway? But if we let everything too loose, then we are vulnerable to cybersecurity. And like what quoting Nicole, this is the challenge that we have to balance. So really a plan that needs to think thoroughly on the local environment is very important. And how much, again, then maybe a balance of not how much we should lock and unlock, but maybe a balance of how much we should integrate and how much interoperability should be enough. So maybe that's the question we should be asking, instead of saying that we should integrate everything and then look at what needs to be locked and what not needs to be locked, kind of thing, right? Moving forward, we also realize that telemedicine itself, relying on a health IT backbone that is created, has their own challenges. And this is not just an internal challenge, but also looking at the ecosystem and the macro environment perspective, challenging the health telemedicine development itself. Infrastructure is one of the key things. We want telemedicine. Does the provider have a good health IT system to support the telemedicine initiative? Telemedicine or teleconsult, for example, requires us or a clinician to be looking or talking to a patient remotely. While we do that, we could only the clinician can only do a certain amount of work in terms of clinical work to a patient itself, and the rest of it has to be supported by other things. Sometimes wearables, sometimes devices that is available by the patient, things like that. But it is not everything that the clinician needs to do can be done on telemedicine, and that's one of the key things as well. So the barrier is still there. We're still unable to remove entirely all the barrier, but this is good for certain kind of patient, but not all kind of patient. So infrastructure barrier is a key thing that we see. Technical skills itself. If we do a lot of telemedicine, we consult with the patient online, primarily the senior citizens as well, which we believe have lesser capabilities to deal with IT and technical issues with regards to their wearables and stuff like that. That will give you more challenges in trying to get through a very smooth consultation, or trying to get through the objective of having to monitor the patient remotely when there's challenges trying to do that. Of course, then you can say that then there should be a caregiver or a family member that would support that. Then that becomes a separate initiative altogether, right? So we're just looking at primarily, if I'm on one patient and I am one physician, can we get telemedicine moving forward in a fantastic way? We see that the skills level has a high challenge for clinicians to try and get through a very efficient teleconsult work that he or she needs to perform. Cybersecurity, we know that if you can remotely access things for the patient to access their records, or you can do remote access for patient to log into your system and then they can go in, this open up the risk. And I think Nicole has elaborated very clearly on the cybersecurity and how risk can be really looked at from that angle. Again, is telemedicine reimbursable? So if I do a consultation online, do I get reimbursed? What is the current rule? Is there a guideline what can be reimbursed? And is there no guideline, or has it been treated that there's no difference between a face-to-face consultation fee versus a telemedicine or teleconsult consultant fee? What is the reimbursement rule? What about technology hype? We say we want to monitor a patient, and everyone goes and buy all sorts of wearables from the brand Apple to the brand ABC made in somewhere in the remote island of the Pacific, you know, and everyone tried to buy all sorts of wearable, thinking that, okay, I have access to some wearable, it's going to be fantastic. Now I can do remote monitoring. I can send my data record to my physician without having to go to the hospitals and stuff like that. But how do we know the effectiveness of these wearable devices? How do we know and ensure that the connectivity will never break? What if there is a gap between a monitoring period, that the data was not transmitting for the last 30 minutes, and the screen shows the exact same data that was 30 minutes ago? What happens if that case happened and the patient is lying there and maybe the family member went to work and she or he is alone at home and the monitoring just stopped? What if that happens? And it may be because of the network, it may be because of the device that they bought. But what is the liability around that? What is the rules, regulatory, and the legislation that goes around that? What is covering that to ensure that such things, we like the idea that we could do monitoring, but do we look at the effectiveness of things like that? Regulatory perspective as well, the legality and the legislation perspective as well. What if the information coming in from the equipment that is unreliable, resulting to a physician that takes that particular and exact number that was transmitted over and do a misdiagnosis? Is the liability on the patient or the liability is on the physician itself? Physicians say, I look at your blood pressure is 160, 110. I better give you some medication now, man. But actually, he's okay. But he's, you know, he gets dispensed with medication and he doesn't know if it's right or wrong. He takes the medication as advised by the physician. So then what happens? Right, and that's just for blood pressure. What if it is for other things? Right, patient acceptance. A lot of patients are still more comfortable to visit a physician and really get some good advice. And when they're doing clinical assessment, we are able to really have a more comprehensive clinical assessment when we are there in front of a patient. There again, it also saves time, because when you require additional diagnostic work, for example, taking a blood test, you are able to immediately move to a next area where a phlebotomist can draw your blood and a blood test can be done. Or if you need a scan, you could immediately go to the imaging department and get the scan done. So again, there's still a lot of patients who finds that telemedicine is a challenge, because if they need all these things, they're not able to do. Physicians get frustrated because they have to wait next appointment to come back, and then the appointment for a patient, a diagnosis for a patient may take days, and sometimes it won't be completed within a day or two. And again, if the patient is remotely far away, that is even bigger challenge, right? For the patient to come back in and out. And then there's communication barrier. Most of the telemedicine platforms do not have a custom feature to ease healthcare communication for persons who are deaf or blind. This is the fact. So this is again things that we are unable to really solve in terms of the telemedicine itself and challenges. Cybersecurity, we know that, and Nicole has highlighted a lot, but this is something I never thought that system can actually cause such a severe incident. A hospital in Germany was hacked. Patient could not get into the emergency department, has to be transported to another hospital. Along the way, she died. So it's really ironic that, you know, a ransomware can cause a patient to pass. And we talked about it in the past as one of the risk hypotheses in the past, but now it's a reality. We now see that such case can and will continue to happen. I mean, the hacker would not have intended someone to die, but you know, these things happen, right? So we see it. One more latest article or news that I found, that during this coronavirus period, the US FBI has found that many hackers are targeting hospitals. And the more we have in terms of IT solutions and integrations and interoperability, we better look at how we are protecting them as well. And again, the question falls back to how much should we protect, right? In summary, we see that in the introduction of telemedicine and health IT is great. I do not deny that the technologies, the medical device, the ITs that are available, the IOMT products that are coming out are fantastic. It really gives us new opportunities to care for our patients. That is really, really great. But I cannot help but to really emphasize, because we've been reading so many RCA reports, we need to recognize that health IT design and interoperability has its own challenges. And we really need to understand and take a second look and a third look and a fourth look, if possible, to all these challenges and problems that keeps coming up. We like how all this remote can work, but we really need to recognize that there is a challenge. Recognizing it means we have to do something about it proactively. Making sure that we have a monitoring program that is robust, that is implemented, and there is a commitment to it, so that we will continuously to find and create risk hypotheses and cover them up before any big problem happens itself. That includes cybersecurity. And to a certain extent, telemedicine, if we see what telemedicine can do and what it relies on as well, maybe there is a need to think about selective use of telemedicine and not, jump on the hype that telemedicine is going to be the future world of healthcare and there's nothing else and telemedicine is going to drive everything. So can we really look at what telemedicine relies on and what it is all about, and how we can selectively use telemedicine to benefit both the patient and the health community itself? With that, I end my presentation. Oh, just before that, I'm talking about all this risk and everything was purely because of patient safety. And this year for Patient Safety Day, we've also been participating as ECRI. And one of those key things that WHO has been talking about is 4 in 10 patients are harmed in primary care and outpatient healthcare. And if with today's wonderful integration and interoperability within the healthcare system, we get 4 out of 10 harm. Imagine if we're going to implement telemedicine on top of a system that is creating 4 to 10 harm, 4 out of 10 harm a day, or 4 patient out of 10 patient harm situation. So we will see a lot of challenges with that. And I can only caution that we will take all these steps in a more well-defined, structured, planned manner. Okay, with that, I end my presentation. Thank you very much.
Yeah, thank you, Eric, as well as Nicole. Probably, is there any questions from the participants that you can actually type it into the Q&A? Just to kickstart, probably Eric, you have been presenting the telemedicine cases and all those things. I understand that you have been in Malaysia for quite some time.
Yes.
How was the situations in Malaysia in the implementations of this telemedicine?
It is not, the diffusion rate for telemedicine is not as high as what we see for the diffusion rate for health IT. So we do see that the health IT adoption are, rising as fast as all the other countries within the region and internationally as well. But the telemedicine is not so much, because right now, honestly speaking, what can telemedicine do? We will really be able to either monitor a patient. For elderly care, it's fantastic. I really support the use of telemedicine for elderly care because of the situation of the patient itself. So that's a very good thing. But for telemedicine, for teleconsult particularly, for people like you and me who has a cough, I cannot even put a stethoscope on your chest to see how bad the cough is. I could only do a certain amount of visual clinical assessment at best. And if telemedicine can be done and require a huge system like that to support just telehealth or teleconsult work, I can do that through WhatsApp, I can do that through Skype, I can do that through Zoom, I can do that through Microsoft Teams. Why do I need a big hype of telemedicine in that sense, if it's only just the consult work that we do? That is why I see that a lot of our physicians are not really jumping into that approach using telemedicine, because the benefit it gives is not fantastic enough. But if you say, I want to monitor patients who are elderly and challenges in moving around, I think telemedicine has a good monitoring potential.
Yeah, probably that goes back to Nicole, whereby, you know, there's actually a big market on the on the tele kind of monitoring system, the vital sign monitoring system. How was that going on at that in that aspects, the sales of that? I understand from Australia they are quite into all these telemonitoring things. Yeah. Nicole, is there any products or any system that you know that provide these features in Philips?
You mean monitoring from the home?
That's right.
We do have solutions in that space, but this is out of hospital. You know, the challenge these days is that we need to also bridge that gap between the hospital and the home. So it's, you know, the thing is, how do you transmit the data in a fashion that it is secure? And that comes back to the security challenge. What do you rely on? A proprietary technology which can send data across many kilometers? Do you rely on wireless data and the challenges that come with the reliability of wireless system? It is a challenge with vital signs, because you need to measure on a continuous basis. It's different if you do spot checks. If you say you measure your temperature and your heart rate, whatever, 3 times a day, you put in the data, and that way you are surveyed by your clinician. That's a different thing. But permanent monitoring is a challenge. If you do it yourself and enter your data at home, that's one thing, but it comes with the challenge of who is doing it. Are you doing it right? You know, are you doing it timely? It's a big space that we need to explore, and it's collaboration between the different stakeholders. It's the patient, it's the clinician, it's the manufacturer. Cannot be achieved. It's not an off-the-shelf solution.
Because I mean there should be a potential for telemedicine to actually to implement in a big way, especially in the rural area. I understand that. So that gap, as you said, is that probably in the past is because of the telecommunication network problem. But I would think that in this stage, whereby the network infrastructures and everything has improved over the years, do you see a potential into a big jump into a big growth in this area, or it will still maintain as what everybody has been saying that is not that effective? It can be Nicole, can be Eric.
Nicole, you want to go ahead with that?
You know, I'm just thinking about a conversation that I had many years ago. I was traveling, and I got stuck at an airport overnight, and then there was I ran into this clinician from the very north of Norway. I mean, Norway is a country. If you go to the very north, at this time of the year, they have a few hours of sunlight during the day, but it's dark most of the time. Guess what? Many people suffer from depression because it's dark all the time. And how do you care about people that are in a remote place? It's a huge country. It's a big country with small population. People live very far. And he told me, and that's 5 years ago, he told me that they're doing a lot with telemedicine to deal with these patients, because you cannot ask them to travel 200 or 300 kilometers to see their doctor for their problem. So I think in remote places like in the north of Europe, or whether it's Australia or parts in Africa, of course, you need to rely a lot more on telemedicine. If I have a cough, as Eric said, and I want to know how bad it is, I would go see my doctor, to be honest.
Yeah.
Just to top that up as well, and a couple of years ago, I mean more than 10 years ago, if anyone remember the Iceland volcanic eruption that caused the entire Europe to actually halted in terms of the airspace. I was in Paris at the point of time with my British physician. So we were stuck. We were already there in France for two and a half weeks, and we were stuck in Paris just the day before we supposed to fly home. We got stuck. he has no choice but to see his follow-up patients that he has done surgery on through Skype. So what we did was that we arranged Skypes from the office or the clinics, and that the patient would come through the monitor, and then and the physician will actually look at the follow-up. But there's only so limited work. So what happened was that we got the physios to be in the room, we got another physician to be in the room so that he can look at the patient, and that he could get the physician to do a certain movement so that he can access. So at that point in time, this is what, at least 15 years ago, and we didn't really have that discussion about telehealth at that moment of time, or telemedicine. We were just looking at how can I see my patient and solve problem. They're waiting for me to see post-op. And now I'm here, now 2.5 weeks, and I can't see my patients. So we decided to try to use Skype. And we did that. We did that for 3 days while we were stuck before we got to fly off, right? So that was something that we can do. But again, anything that requires a good clinical diagnosis, it's very challenging to do it remotely. And I understand if people are from remote areas, and even if you could diagnose the patient just based on what you can see in the monitor itself, then there is again a challenge of logistics to deliver the medication. The challenge of the physician to think about what level of dosage to prescribe for the patient itself, based on just what you can see on the screen. And should I give you the heaviest dose? Yeah. Should I give you the lightest dose? Should I give you what? So again, usually maybe to really provide certain kind of care and medication so that the patient becomes stable and get a chance for him to travel very distance to see him personally would be an ideal solution. But again, to stabilize the patient now, you still have to transport, and the logistic issue of sending medication or certain care or products to the particular patient reaching the doorstep itself. That will take another couple of days. So again, whether it is worth doing that versus really coming all the way and get it sorted out once and for all, it's a debate, right? It's a debate. But we do see, like I emphasize, for patient monitoring, it will be very nice, particularly for elderly care. It will be very nice.
Where the patients are in a state probably for monitoring, stable states, and not for emergency purposes. Okay, I think there's one question in the Q&A that Mr. Leong asked Nicole, talking about how do you change password in medical device as assisted by IT. I think along with that, I have another question that add on to this, that in the future, will there be products that medical products that actually put in antivirus software too? Yeah.
Good question. That's a very good question. I think Nicole would probably have the answer.
You know, password protection is a big topic. I mean, that the three things that we always say that people should do is password protect, give access to the least privileged, you know, then encryption, and there's patch management. These are the three pillars. And of course, password is a big thing. And, you know, it sounds funny, but sometimes we have to say, don't put your medical devices in a public area. If you want to protect your system, just don't put it in the hallway or accessible to anyone. I mean, it's just a stupid thing, but access protection starts with physical protection. Now, IT says change your password every 3 months. And people are even asking us to protect our patient monitoring system, which is supposed to run 24/7. Why do you want to password protect something that needs to display vital signs 24/7? I can understand that someone wants to protect a patient's name, yes, but you need to be able to see what's going on. You need to see the alarm. You need to see the vital signs, yes. So I'm using that extreme to say, in that case, you really have to think about where you put your lock, your password. If I have a system that allows me to look at retrospective data of any patient, I mean, physicians do that. They take time, they go into their office, they review stuff. Yes, I can put password protection there because it's not time critical. It's not about the current state of the patient. So I have sensitive data in the system, and I can password protect it on my PC in my doctor's office. I can put the normal lock. So there's, as a healthcare provider, as a manufacturer, we can put locks in place everywhere. Even a patient-worn device, a telemetry device that you would use in hospital, you can password protect it. You can. Most customers don't, because it's tedious. What if you don't remember the password? You cannot use that device because you forgot the password. It's all about balance. With telemetry, you know, I don't mind. I would say it's not life critical. It's something that a walking patient is wearing. It's okay if I have to mess with that. If I'm in an intensive care unit, I don't want to mess with passwords. You can put it, and you know, it's again about balance. What I think is reasonable is to say, I can protect or hide my personal data, the name of my patient, on a patient monitor, but I still need to see the vital signs, and then I can come with my tag and do, you know, get access via password or via a RFID scanner, and see the patient name as well. I mean, I can stream to say hide the name and the birthday and the age, whatever, and only display that when someone enters the right password. That is something that we're debating these days. No one would have thought about that 10 years ago, that you need to hide the name. But these days, people are asking, I have visitors in the room, can you please hide that name? Sometimes we're taking things to extremes, but as a manufacturer, we can provide the locks. It's about the workflow, and it's about risk management, and that's serious. You need to see where are you putting your patient at risk. Complying with IT's requirement to set passwords, what does that do to, in a general care situation, no problem, but not in an intensive care. My personal opinion.
Yeah, sure. Our time is up. Probably, I think there's always a chance and a need for the biomedical engineers to talk with the clinicians and even the IT people. That is important to actually to strike a balance in all those things. I think communication is important. One last comment from George. They say a good idea is to train the patient to describe the symptoms and most precise and details as they are able to while using their telemedicine medical devices. Well, just to train the patients there. Okay, thank you very much, everyone. I will pass the time to Dr. Gordon. Yeah, Gordon, you're there?
Hi, yeah. So yeah, thank you,